Muy buenas tardes a todos. Gracias por conectarse.
Good
Gracias por
afternoon, everyone. Thank you for connecting and listening in. We're going to start the webinar on hearts in the Americas and kidney health for all. We want to give you some brief instructions.
pueden, por favor, dejarnos un saludo en el chat del país de donde nos están
In the
escribiendo
chat box,
su cargo, si así lo desean.
write in your name and the position you hold by way of greeting us. And in the bottom, on the bottom of the screen, you'll see a icon for chatting where you can pose your questions for panelists or any issue that you would like to raise, any question you would like to ask in the chat button. And behind the scenes, we will select the questions that we can talk about during the Q&A with the panelists and the commentators. Without further ado, I give the floor to Dr. Pedro, the regional advisor, Pedro Ordóñez, who is the leader of the Hearts in the Americas program, for him to kick off this webinar, this initiative. Thank you very much, Jenny. And I thank all of our colleagues who are listening in to this webinar that we are holding on the occasion of the International Day of the Kidney. It's very important for us to talk about kidney health. Today is March 10th. Unfortunately, we're still in the midst. We have not yet emerged from COVID-19. I want to call everyone's attention to that. There are many countries that are still going through a very difficult time. Many citizens have not yet been vaccinated. The director of PAHO has made a call to not drop our guard, to not think that we're past the COVID pandemic. We have to step up, strengthen our capacities to face the pandemic and to be able to, at the same time, be able to provide the services that were affected by the pandemic. And kidney health services are some of those services, and we're going to talk about that when we celebrate the World Day of a given problem. Today, the World Day of Kidney Health. That's done with the purpose of calling people's attention on a worldwide health problem. And this health problem that we're talking about today is kidney health, kidney diseases, and this is a serious, grave problem throughout the world. This is a problem that we haven't been able to contain. In fact, it's rising in some places in our region as one of the regions in which we see that this is one of the most serious problems. In coordination with our partners from Latin America, we have decided to hold this webinar to celebrate this day and to call people's attention on what we should be doing and are not yet doing to strengthen, bolster these measures. So this is going to be proceed in the following way. There are going to be 3 sessions. The first is going to be devoted to kidney health for all, unfinished business. There is going to be a presentation, and we'll be following up each one with a comment period. Another one on comprehensive kidney health in the first level of care, and we focus on kidney health here from the standpoint of the first level of care, primary health care, and then a third session in which we are going to talk again about what's at stake in addressing kidney health for all, Hearts in the Americas and kidney health. Now, I reiterate our words of welcome. We have 250 people now in the room in the Zoom room, and we are broadcasting on our YouTube channel as well. And so we will have the opportunity to, that is, anyone who couldn't be here today will be able to view this webinar after the fact. Without further ado, I give the floor to Dr. Guillermo Alvarez. turn on your camera, please. Guillermo is the president of the Latin American Association of Nephrology and Hypertension. He is our first presenter. You have the floor, sir. Please proceed, Dr. Alvarez.
El equipo técnico, por favor, debe poner el video del doctor Guillermo.
Could we please have Dr. Guillermo Alvarez's video put on the screen? These things can happen. So, please, sir. Good morning, everyone. On behalf of the Latin American Association of Nephrology, I would like to greet and to congratulate Pajo and Dr. Pedro Ordóñez, Andres Resende, and Jennifer Rodriguez for holding this webinar on hearts in the Americas and kidney health for all. This activity takes place within the framework of the agreement between SLAN and PAHO over the next 15 minutes. We will be presenting on the current state of play of kidney health in the Americas. I have no conflict of interest in presenting this. This is an activity which takes place within the framework of the World Day of Kidney Health. The World Day of Kidney Health is an initiative of the International Nephrology Society, and it's held every second Thursday of March, and it has as a goal to shed light on chronic kidney disease and to set strategies for diagnosis and to ensure equitable treatment. This is our schedule during this conference, and chronic kidney disease affects the whole world's population. Nearly 10% of the world's population has chronic kidney disease, but in Latin America, in Europe, in the Middle East and Asia, Eastern Asia, these are the four zones in which chronic kidney disease is more prevalent. But I think we win in Latin America. Why? Because in our region has under-reporting, under-registration of this. More than 12% of our population is affected by chronic kidney disease. If we analyze reports on kidney dialysis and transplants, we see the growth of chronic kidney disease. It has grown from 91 to 2019 by 627%. What that means is that each year there is an increase. It increases every year. That is a public health problem among our populations. Now, in 2014, PAHO and SLAN agreed to set a goal for the prevalence, the rate of prevalence for our region to be 700 sick people per 1 million inhabitants. Now we supersede that because in 2019, 866 people per million is our prevalence. Now, on the right, if we look at the country breakdown of prevalence, we see that nearly 50% of countries of Latin America have not reached this level, this rate of 700 per 1 million inhabitants. This is influenced probably by the fact that there's an under-reporting in our country, and the reporting is not done in an optimum way, and the system of reporting needs to be strengthened. If we take a look at the growth and why this happens, one of the reasons for this growth, it's influenced mostly by hemodialysis therapy, which also grows, and that strikes us because peritoneal dialysis and transplants. These are the most cost-effective therapies, and they have not sufficiently been developed, and they have been held back, have fallen behind. They have not grown significantly in our region. This type of therapy has not grown. So when we look at the issue of affordability or access to such therapies and coverage, 62% of countries in Latin America have some type of problem as far as access to such therapy. To therapy in our countries is not complete either because there isn't an installed capacity of dialysis or the rate of or peritoneal dialysis has not been is not sufficiently widespread. Kidney transplants have not been encouraged. That's why 52% have this problem of access. 40%, when talking about coverage now, close to 40% of countries in Latin America, those therapies available are not 100% available. That brings with it economic problems, and that ultimately undermines a patient's ability to have access to basic services and foodstuffs. Now, if we look at the global burden of this disease in our region, those low-income countries, Bolivia, El Salvador, Honduras, Nicaragua, of the lowest income, they are the ones that show a lower prevalence compared to the middle-income countries and the high-income countries. And what strikes us in these low-income countries is that these are the countries with the highest mortality rate, the largest number of years lost for disability daily, and the lowest number of nephrologists per 1 million inhabitants. Another cause that has bearing on chronic kidney disease are non-traditional cases. This is a pathology that affects Central America, the whole swath of Central America, and we stress here those main areas where there's a higher incidence of non-traditional kidney disease, chronic kidney disease. This affects mostly the Pacific Coast countries, mostly working men. But we know that nowadays, women and children are also being affected by this. And this is one of the main causes of mortality in this zone. There are cities, populations in the region in which nephropathology is one of the highest causes worldwide for chronic kidney disease. Now, what are the challenges we face in providing kidney health and to provide prevention services for kidney disease such that patients don't suffer from chronic renal deficiency or failure and don't need ultimately kidney transplants? We see a whole host of challenges. You can see that on the slide, but what really stands out is one of the problems is that the healthcare systems don't identify chronic kidney diseases as a public health problem of any significance. That is a very important matter because we all need to pull together health ministries, patients, national governments, civil society, to fight against chronic kidney disease. And we need to fashion public policy for kidney health that is focused on prevention, diagnosis, and treatment. multiple treatments, and we also have to legislate, create legislation so that we can have a programmed and systematic organized approach to reducing kidney disease. Now, given this silent epidemic of chronic kidney disease in Latin America, what can be done? What have we done at SLAN? First, the fact that SLAN has joined PAHO as a non-government organization, working with it, that in 2015, these ties of cooperation with PAHO have enabled us to fashion working plans so that we can have increase the records and notification of kidney disease, the reporting of kidney disease, and also to assist in the training of first primary healthcare doctors, such as this course that was carried out. More than 25,000 people have taken this course, and also the peritoneal dialysis, which is a multidisciplinary first level course, or for the first level of care, to offer assistance to those patients with chronic kidney disease. We reach out to health ministries, working with health ministries for us to analyze the transplants of kidneys that take place in Latin America, to keep a record of them. Bolivia, Honduras, Nicaragua are countries where we don't have these records up to date. Mexico and Belize do indeed have record keeping on this, and you can see there are countries where there is a registry of these cases, but we still have to improve the record taking so that we can improve figures on prevalence and get a handle on who has what rate. Now, working with the International Association of Nephrology in 2017, a policy forum was held on nephrology, kidney health. This encouraged the promotion of kidney health and the prevention of kidney disease as an urgent and important action that needs to be taken to reduce chronic kidney disease. At SLAN, the Latin American Society of Nephrology and Hypertension, we have done surveys. We see that 33 countries in Latin America don't have a kidney health plan or program. 62% of countries don't have a registry of chronic kidney disease prior to the dialysis stage. There is no legislation that makes mandatory the reporting of the glomerular filtration rate, which is how we can ascertain who has kidney disease. 33% of countries don't carry out training at the first level of care on prevention, detection, diagnosis on a timely basis of chronic kidney disease. 62% don't have a kidney health law. This is significant because in those countries in which there is legislation on kidney health, in those countries there is a significant rise and development of infrastructure to prevent and to treat better and to tackle chronic kidney disease. Now, at SLAN, we have the Kidney Health Committee that has put together work plans to act on the findings of the survey. Promoting early diagnosis is one of the goals through advocacy and policies for reporting, for labs to report the rate of glomerular filtration, as well as cardiovascular risk rates. That would be wonderful if we in the future were able to include on the hearts platform urine exams for GFR. We have a board. As the board, we do have a strategy. The national meetings, we'll be meeting with health ministries and nephrology societies. At these meetings, we will talk about the importance of registries, of coming up with kidney health plans, of carrying out studies to reduce mortality of patients on dialysis, and also greater penetration of peritoneal dialysis, and as well as kidney transplants. So in 2018, in the Dominican Republic, at the Central American and Caribbean pediatric nephrology meeting, we met with the hemisphere and also with the President of the Republic, the then President of the Republic, in which the President of the Latin American Association was also there, and the board of the Dominican Nephrology Association, to put together a plan to develop a nephrology in our country, in Central America and the Caribbean. Overall, on our agenda, we also are encouraging the creation of kidney health programs. And these are the 7 points included in that kidney health program. And I'm going to stress the promotion of kidney health in the population, first and foremost, so that we can be effective in promoting kidney health. And that calls for there being public policy that helps us to encourage the population to adopt measures that would protect their kidney health. So what have we done by way of education? Beyond the kidney health committees, we have 22 working committees that each one devoted to carrying out educational activities, an aggressive educational program. We are carrying out different activities such as weekly webinars, and recently we have put together a committee that provides ongoing training online, practical hands-on training online. This is how we seek to rise or to meet the goal we set of closing the gap of knowledge, the knowledge gap, for us to assure better kidney health. So guidelines, protocols, recommendations, and to raise awareness and knowledge among our population and among doctors at the first line of care and nephrologists. So, by way of conclusion, I would say that it's necessary for us to spur the implementation of kidney health policies focused on prevention, diagnosis, and timely treatment. We have to request closer collaboration among those responsible for promoting kidney health. This includes health economists, nephrologists, organized civil society, to define and ensure better kidney health strategies that are equity-based, to spur kidney health policies in all countries, ensuring affordability, accessibility, equity, equality for all patients, regardless of whether the healthcare system is subsidized, private, and we have to strengthen national registries of chronic kidney disease, dialysis transplants, and other variables. Now, with this, I conclude with this sentence by Dr. Richard Horton, the chief editor of The Lancet. He says, we need to translate words, promises, and commitments into meaningful change and action for our patients in our communities and our communities. With these words, I bid farewell. Thank you very much for your attention, and we stand by for your questions.
Excelente presentación,
That was a
Guillermo.
great presentation, Guillermo.
Excelente y inspiradoras las palabras de Richard Horton.
And Richard's words are inspiring. That is, to turn words into actions. Before giving the floor to the next presenter, I would like to greet everyone who's listening in today, to our audience, and I will mention the countries that we have: Central America and the Andean region. Central America, we have Costa Rica, Panama, the Dominican Republic, and El Salvador, and Mexico. We also have Peru, Colombia, Ecuador, Bolivia, and Venezuela from the Andean region. Now, if I overlook some country, please put that in the chat. Reach out to your colleagues, greet them. Mexico, Costa Rica, Panama, Dominican Republic, El Salvador, and then Peru, Colombia, Bolivia, Venezuela, I mentioned. Well, that would be more South America. So I'm happy to see so many people from Central America and the Caribbean. Let us know you're here in the chat. Let us know how committed you are to kidney health on this World Day of Kidney Health. After that very illustrative presentation of the state of play of the situation in Latin America, I now give the floor to the a doctor from Chile, Antofagasta, and also another speaker from SLAM. And we'll hear about the Heart Initiative. Mr. Zúñiga.
Muy buenas tardes a todos.
Good afternoon, everyone. First of all, I would like to congratulate Dr. Guillermo Alvarez for his excellent presentation. The truth is, that is a call to action in and of itself. Second, I would also like to say, and as we have just seen, chronic kidney disease is a very important public health problem worldwide and a growing problem with huge effects, negative effects on individuals and societies if we don't act today with the clear objective of reducing this growth. Chronic kidney disease will have a health and economic effect that is impossible to calculate. Now, this doesn't only have a negative impact as it can lead to the need for dialysis and death, but it also has an important negative effect on the rise of cardiovascular risk, and life expectancy drops as a result of this significantly. Now, despite a big part of this growth, the fact is it's preventable with early diagnosis, treatment, and changing factors such as hypertension, diabetes, and obesity. Unfortunately, chronic kidney disease is viewed by our patients as an unavoidable consequence of aging, the result of chronic complications of other diseases that really only affect a small number of patients, they think. That's why chronic kidney disease is perceived as a relatively low important matter. And that's why it's so urgent for us to act and to prevent the deterioration of patients' health owing to kidney disease. There are those patients with high risk of progression of the disease. But the fact is, among the healthcare workers themselves, there isn't as much awareness as there should be. This is the time for us to change the outlook, to focus, and to have a more public health approach to this, a very open one, and to bolster the concepts and approach of prevention and to slow down progression of kidney disease without overlooking social determinants of our current healthcare situation. we live in a situation in which our patient's perception is something that we can influence through social networks and the media. It's absolutely necessary for us to increase the knowledge that people have on chronic kidney disease. And so this is an opportunity here for us to come together and to look into this from different vantage points and to include all the different players, patients, healthcare providers, and of course, the academic sectors and healthcare authorities.
Heart, at the heart itself of heart care in our population, is a key initiative for the care of kidney health, because by adopting healthy lifestyles, we can promote proper kidney health, and also through the adoption of a protocol to control hypertension based on evidence and standardized, we can also improve the control rate for hypertension at our healthcare centers, and also to control one of the main causes of chronic heart and kidney problems. For the proper management of our patients, we need to include key elements, validated devices that allow us to have a proper diagnosis and better treatment of our patients. Also, management based on heart risk also places our patients who have kidney disease at a point when we cannot delay initiation of treatment and diagnosis, and we need to be highly ambitious to reach the hypertension control goal. We also understand that our kidney patients require management by the whole health team, and we need to assess them from the point of view of nursing, nutrition, psychology, and social aspects. If we also need to make progress with control, we need to know as accurately as possible our numbers, our local situation, our results, to be able to address to our results through a proper registration system. Heart also has a specific module for diabetes management that continues to be one of the main causes of chronic disease in the world and in our region. For all of that, as Mr. Alvarez just mentioned, we need to have an active participation in improving the heart health and also the kidney health in our population, and the Hearts Initiative is key in this. Thank you very much for your attention. The interpreter apologizes, but the gentleman is muted. I just wanted to thank Dr. Eric Zuniga for this excellent comment, highlighting what Guillermo had already mentioned in his presentation, and also by placing the emphasis on the opportunity we have with Hearts implementation to look into all of the causes of chronic kidney disease that are hypertension and diabetes. We are going to come back to this during the question and answer period, but I wanted to strengthen this idea and now send my greetings to Brazil. We have Uruguay. It is a pleasure also to greet Uruguay. It is one of the 4 countries in the Americas that is still not part of the Americas. We also have Chile that has a large number of participants. We also have Argentina and Venezuela. Then I'll move on to the Caribbean participants, because mostly all of their countries are represented here in this session on the World Day of Kidney, and I would like to send my greetings to South America, and later on I will mention the Caribbean countries. So let's move on to the second session. That is the comprehensive management of kidney health at the first level of care. And let me introduce Cristina. Carlino, who is a nephrologist and also a member of the Kidney Health Committee with the South American Association. Dr. Carlino, please go ahead.
Producción.
I am asking the well, first of all, I'd like to thank Pajo's invitation and the trust of the members of the Kidney Committee. We cannot see the video for early detection and also treatment of kidney disease at the first level of care. Let me check with the company that is in charge of production. Please go ahead. It seems we got sorted out. First, I would like to thank Pajo for the invitation and the trust of those who work with the committee to address early detection and treatment of kidney disease at the first level of care.
Parece que estamos teniendo.
Chronic kidney disease includes all of the situations that lead to kidney impairment and also persistent damage for over 3 months. The most severe presentations are the need for kidney substitution therapy and also early mortality, cardiovascular mortality. This is just the tip of the iceberg. It is not infrequent also for the patients to be asymptomatic until later stages of the disease. This lack of knowledge on the existence of kidney disease also leads to the loss of the opportunity to participate with early measures to delay cardiovascular and kidney disease and also the late review at the level of nephrology. It is also important for the health team to think of the kidney disease and carry out an active screening among the risk groups. Various registries worldwide show us that between 10 and 12% of the population suffer from chronic kidney disease. In Latin America, there were no studies determining its prevalence until a population survey was conducted in Argentina in 2018-2019 that determined glomerular infiltration, and this survey determined a prevalence of chronic kidney disease of 12.7% that increased when subgroups were studied, such as those that were diabetic, people older than 65, and hypertensive individuals. When we assess the presence of disease in these individuals, only 11.9% expressed that they knew that they had a diagnosis of kidney disease. There are several methodologies for the assessment of kidney function on a daily basis. We are just going to agree that uremia is not useful for this type of disease as to a creatinine, even though it is the one that is used the most. The relationship between its value and the glomerular filtration can show a drop of up to 50% until the creatinine concentration goes above the benchmark value. It changes with the gender, the ethnic group, the consumption of some pharmaceutical products, and also some lab results. Creatinine is not enough to assess kidney disease. As to the creatinine clearance, this underestimates glomerular infiltration, since this is not only this flows in more than one way, and there is also great variability due to mistakes in the collection, in the 24-hour urine collection. Taking into account the limitations, a series of equations were developed to properly estimate glomerular filtration through serum creatinine based on age, the gender, as well as the ethnic group. These formula are the ones recommended by various guidelines, in particular MDRD, that was the first one to be developed from a group of individuals with chronic disease, and more currently. We have CKD EPI that is more accurate, but also as for the standardization of creatinine. In spite of the various recommendations, most of the labs do not report on the glomerular filtration levels, and doctors may overlook the presence of chronic kidney disease unless they are specifically looking for it and they are using the formula available on various websites or medical calculators. So to report on glomerular filtration in a mandatory fashion, anytime that creatinine is expressed in a dose is the key to identify this disease, and the doctor that is not a specialist may learn of a problem with the kidneys, and in this way the patient could benefit from early intervention. The presence of proteinuria and albuminuria identifies a higher risk group of patients and also a group of patients that may have higher mortality and morbidity due to heart disease. Healthy adults eliminate less than 150 milligrams of proteinuria and albuminuria in their urine on a daily basis. Both are assessed in the first urine sample of the morning, and it will always be referred to the concentration to minimize the effect of dehydration. The presence of these two elements is more sensitive, but as this increases, the ratio offers a better approximation. These ratios have an excellent correlation with proteinuria and albuminuria after 24 hours, and this first determination will be used for special cases, in particular in the case of proteinurias at the nephrotic level. For the initial screening, we can use reactive strips that detect proteinuria as of 50 milligrams per liter. And if this turns out to be positive, we quantify proteinuria and we also establish the ratio to study. But if the strip is negative, albuminuria will be dosed, and then we will use proteinuria, cretinuria, in particular in diabetic individuals and those who have a high heart risk. In all of the cases, proteinuria and albuminuria should be confirmed with a second sample within the 3 months. And what is the implication of having a diagnosis of chronic kidney disease? This heat table shows us the risk of progression, mortality from better to worse as the filtration changes and the proteinuria increases. The higher risk is in green, followed by yellow and red, which express increasing risk. It should be mentioned that those that have chronic kidney disease may die of heart disease, and this risk of death is higher when the nephropathy increases. Therefore, the stage of the kidney disease will determine the kidney and cardiovascular diagnosis and will lead to treatment. And also, depending on the glomerular filtration, there could be a need to modify a dose or also the restriction for the use of the medicine, and this also be having an impact on the hypertensive treatment and also the medicine to reduce glucose in diabetic patients. The first measure as part of the strategy is to slow down kidney progression and kidney risk is to actively look for it in the risk groups, since there are no specific symptoms alerting us of this, and this will be done through the proteinuria and albuminuria. The proper control of hypertension and diabetes are mandatory and will be addressed better in the next presentation. The treatment with proteinuria has to do with the inhibitors of the enzyme with enhanced benefits on the effects of cardiovascular disease and death, and it will also be based on the adaptation of the protein intake. Smoking should cease, and we should also look into other situations that also lead to this type of severe proteinuria, such as dehydration, given diarrhea, vomiting, or even the use of diuretics, the indication of nephrotoxics, in particular steroids and IV drugs, and in particular in connection with the risk factors for cardiovascular disease, we should also consider kidney patients as high-risk patients. We should also pay special attention to situations that show the need to refer the patient to nephrology due to remission. And even though this problem may be independent of the cause, it is important to indicate that there are some pathologies that may require special treatment, such as glomerulonephritis or other systemic diseases with kidney and hypertension. And the goal is to identify and treat those that have the highest risk for the kidney and the heart, and they could benefit from early consultation with nephrology. We should also pay special attention to the presence of moderate and severe kidney disease presence, and also the change in the glomerular filtration, the presence of hypertension refractory to treatment with full doses, including diuretics, and also the presence of 300 milliliters per gram in case of IFGE, in case there is no justifying cause and no arterial control to block some of these substances, and also the presence of hematuria, non-neurologic hematuria that allows us to discard other types of treatment. To sum up, we can say that in a healthy population or in a risk population, it is key to have primary prevention to prevent the development of chronic disease, cardiovascular disease, by controlling the predisposing pathologies such as diabetes and hypertension and the other diseases that can be modified also in terms of treatment and based on the current consensus. When we see proteinuria or diminished IFGE, we diagnose chronic kidney disease, and since these comorbidities coexist, the final treatment of this kidney disease will lead to the coordination among the various members of the team, together with the strategies for these non-transmissible diseases. The goal here is to have secondary prevention together with the prevention of the progression of the kidney disease and heart damage, together with the measures that we described in the previous slides, and also going back to the use of YECA and ARA2. And given advanced kidney disease, we need to have follow-up, also dialysis, and also in this case, we would be including replacement therapy or palliative care. Treatment will be based on proper nutrition, the correction of anemia, and also the metabolic symptoms, and also to determine whether we need peritoneal or vascular access for early treatment, and also to complete the necessary vaccination against hepatitis B, influenza, and pneumococcus. I would like to take up this opportunity to invite you to attend the course on the prevention and management of chronic kidney disease for the first care level team that we have been holding starting in 2016. This is organized by PAHO. We have more than 35,000 individuals who have registered, and the Commission on Kidney Health is currently updating content and also reviewing the topics. Thank you very much.
Muchísimas gracias.
Thank you very much.
Muchísimas gracias, doctora Cristina
Thank you,
Carlino,
Dr. Cristina
por esta
Carlino,
detallada
for this
presentación
detailed
sobre
presentation
la detección
on
temprana y
the early
abordaje
detection
inicial de la
and
enfermedad renal
early
crónica
treatment of chronic
en el primer
kidney
nivel de
disease at
atención.
the first level of care.
Para reaccionar a esta
To react
presentación,
to
yo
this
quiero
presentation, I
invitar
would
al
like to invite Dr.
Pablo Ríos,
Pablo Rios,
miembro del Comité
who
de
is a
Salud
member of
Renal de
the Kidney
SLAN,
Health Committee
que va a comentar
of SLAN,
y va a poner énfasis en lo que
who
la
will
doctora
be
Carlino
making some
acaba de
comments on
presentar.
what Dr.
Adelante,
Carlino just
doctor
presented.
Ríos, por favor.
Dr. Rios, please go ahead.
Bueno, es un placer
It
y
is a
también quiero
pleasure,
extender agradecimiento
and I would also like
SLAN
to
y a
thank SLAN, PAHO, for this active participation on this world in which we celebrate the opportunity to prevent kidney disease. And I would like to congratulate Dr. Carlino for her excellent presentation. And I would like to highlight 2 or 3 aspects from the presentation by Dr. Carlino, which in my opinion are extremely important. On the one hand, to know that creatinine in itself is not enough to know the actual scope of the kidney disease, and it is important to estimate glomerular filtration with formula to get to see the actual kidney impairment. The one that we use the most is the one that Dr. Carlino just informed, as well as MRDN. And it is also important to have the study of the albuminuria, that is microalbuminuria, for the detection, the early detection of the diabetic nephropathy. This is key for the diagnosis of this disease. In patients that have already proteinuria, it is very important to quantify it, and to that end, we have 2 tools that are the proteinuria, creatinuria rate, which is equivalent to proteinuria after 24 hours and allows us to see the evolution and the response to the measures that we may be implementing in an attempt to diminish proteinuria as a therapeutic goal. The third comment is the importance of reaching an etiological diagnosis of the kidney disease. As we said before, about 60 to 70% of the patients with kidney disease have their origins in diabetes and hypertension, but there is another percentage of patients that have a different origin for their nephropathology. It could be a kidney disease, it could be an obstructive kidney disease, or it could be a hereditary kidney disease, it could be a glomerulopathy, but it is also important to make progress in the etiology to offer these patients accurate treatment to avoid dialysis. I would also like to mention that cardiovascular disease related to hypertension. For every person that is receiving dialysis in Uruguay, we have 3 patients who die because of cardiovascular causes, and it is very important to know that these patients that have kidney disease, low glomerular filtration, are very high risk, and we should also have the cardiovascular disease or study to be implemented so that we do not have early death among these patients as we see in most cases, and we should also have early diagnosis of the cardiovascular situation. Another aspect to highlight is that once we see a patient with nephrologic problems, we need to manage cases so that these patients are not lost to follow up. This is key in these kidney programs, the patients that can attain continued follow-up with the nephrologist and also with the multidisciplinary team that includes nutritionists and nurses. These patients have 30% less likelihood in 3 to 4 years, other than those that are lost to follow-up, to survive. And patients that cannot follow, that following these prevention programs can stabilize their kidney function in 60% of the cases or slow it down. We have had almost 7-year difference in the time of admission to dialysis for those patients who are lost to follow-up and as compared to those that have
los comentarios.
kidney controls. And to complete my comments, I would like to establish that those patients that have chronic kidney disease in advanced stages 4 or 5, it would be important to have pre-dialysis treatment, because these patients are also very high risk from the cardiovascular point of view, but also they can die. And it is very important to assess other factors such as the bone metabolism and also anemia, and they require support with the nutritionist that is done more closely to diminish or mitigate everything that has to do with the symptoms that occur when filtration goes below the levels that we just mentioned. So I would like to conclude my presentation, and once again, let me reiterate my appreciation. Thank you very much, Dr. Rios, for your reactions to the presentation by Dr. Carlino, and also for highlighting these topics that are so important for prevention and management of chronic kidney disease. I would like to pause briefly before the next presentation and send greetings to our colleagues from the Caribbean that have joined us, Dominica, Bahamas, Trinidad and Tobago, St. Lucia, Guyana, Barbados, Jamaica, that is another country from the Caribbean that is still not part of HEARTS, and I would like to tell Uruguay and our colleagues from Jamaica to tell them to continue to participate in understanding how HEARTS works and also how we can promote it as a viable, pragmatic solution to improve first level of care in the various countries, and also for the prevention of kidney and heart disease. We have Suriname, Jamaica, we have proper representation of the Caribbean in this webinar. And now I am giving the floor to Dr. Alfonso Cueto with the Kidney Health Committee. He also presided the Latin America Association of Nephrology, and he will be referring to the impact of controlling diabetes and cardiovascular disease, and the impact of these risk factors is so high and so severe in the region of the Americas. Please go ahead, doctor. Good morning. My name is Alfonso Cueto Manzano. I would like to thank the organizers of such an important event here with PAHO and the Pan American Association of Nephrology and Hypertension as to the impact of controlling hypertension and diabetes for the prevention of kidney damage. I would like to address these topics. Diabetes mellitus as the cause for the chronic disease in countries such as in the US. For over 30 years, the main cause of chronic kidney impairment is diabetes mellitus, mainly of type 2, followed by hypertension, as you can see, which are far from the other causes of chronic diseases that in the past were the main ones. And in our region, with less complete data, but also less consistent data, we can observe in this information from transplant patients that diabetes mellitus takes first place, and these are the main causes of terminal kidney diseases in our region, and together they can amount to 50 or 80% of all the cases. And this also gives us an idea about the importance of diabetes and hypertension in connection with chronic kidney diseases, and also sometimes it has to do with environmental genetic aspects, and oftentimes they occur together or at the same time. And this also justifies better analysis and also in-depth management of these situations.
Now let's take a look at the impact of a control of chronic kidney disease. Different studies, such as UKPDS, ACCORD, ADVANCE, or VADT, have analyzed the impact of intensive control of glucose measured against a standard control. And what we have seen consistently is that both the strict control of glucose we have a level of between 6 and 7 of hemoglobin, and that prevents the development of micro or macro albuminuria. And where the results have been less consistent has to do with renal filtration. We've seen an effect in the increase or development of chronic terminal chronic kidney disease. In some studies that we have followed up on after the clinical test stage up to 10 years on DCCT or advance in these formats, what we've seen is that those subjects that were enrolled in the intensive control group of glucose had lower levels than those in the standard control group. That is a lower GFR rate. Now, what we've seen is that there is an important effect, a marked effect, as cardio or nephroprotectors. And if we look at this group of the inhibitors, glucose type 2, in which in the group we saw a similar effect, and you can see the results of the study and we see similar results. Now, in this case, compared with the placebo, compared to dapagliflozin, there was a significant impressive drop with the use of dapagliflozin, and there was a reduction of by 50% of kidney failure or death, and other impressive results in comparison to the placebo that were observed, other variables looking at with specific renal responses or by cardiovascular death or kidney failure or by any other cause. And so this type of medicine can have promising results. And so we can summarize this by saying that intensive glucose control prevents development and progression of albuminuria, and that it most likely can also bring down the glomerular filtration rate loss. If we want to see these benefits in these patients, we have to apply it early on in their chronic CKD, and also the families of medicines, SGLT2 inhibitors, have shown a reduction in progress of CKD. Now, as far as the impact of the control of hypertension, arterial hypertension, different studies have shown very interesting results, many in fact, I should say, but it's easier to arrive at a consensus regarding the degree of control that arterial hypertension should we have in terms of cardiovascular results. It's a little bit polemical as far as the results, the kidney renal results. Now, here we can see in different guidelines in the US and Europe, Diabetes Association of the US or CDOQI, the arterial tension or pressure limit, it depends on the protein content in urines, or the person is a diabetic or not. If there is cardiovascular risk, generally speaking, those patients that have a higher excretion of albumin, urine albumin, it's recommended that there be more close monitoring of arterial pressure, and if it's greater or equal to 130/80. However, in 2021, clinical practice guidelines for the management of blood pressure and chronic disease was issued by KDIGO and has recommended that in adult patients under 120 millimeters of mercury be the level at which it should be kept using standardized office BP measurements. Now, this apparently because we're getting an increasing amount of evidence that this type and magnitude of control can have better cardiovascular results. This is subject to discussion because there are many authorities who think that this is inappropriate and not achievable in patients with CKD, and that this can actually be dangerous in routine daily practice of patients with CKD. We do have to bear in mind, however, that undesirable developments such as hypertension, we have to watch that to avoid complications. These guidelines also recommend that the patients with CKD and hypertension without diabetes, that this be applied, renin-angiotensin system inhibitors. With less evidence, it's suggested that this be applied in those patients that have albuminuria that's moderately higher. Now, it's recommended that these patients, regardless of whether they have moderate or severely increased albuminuria, it's recommended that the combination be avoid of ACEI or inhibitors in these patients with CKD, whether they have or not diabetes mellitus. Now, in any patient with chronic renal disease or hypertension should receive thorough, complete, comprehensive, holistic treatment to reduce the risk of progression of cardiovascular and kidney disease. And so sufficient control in arterial pressure or glycemia should be kept. And also they should avoid negative lifestyle behaviors like smoking. They should exercise and watch their diet, nutrition. This can be done. That is, multidisciplinary approach is the most effective. This takes me to the last point that I want to touch on, and that is the control of all of these different aspects that I've just mentioned. It's easier to carry them out if you look at the bottom of this iceberg that represents chronic disease. And so this is the primary care level in which we see the vast majority of patients that probably don't yet have CKD, but are at risk of developing, and those who have high arterial blood pressure or diabetes. And much can be done to keep there from being a progression of harm. Now, if we look at the extreme cases at the top of the iceberg, or in most cases, those who are somewhere in between. So the challenges are to develop prevention, diagnosis, treatment problems for chronic kidney disease. We talked about this in prior talks, to implement educational interventions for patients and professionals, especially from the standpoint of primary health care, because we've seen that with education, patients, that is at the primary healthcare level, patients can be diagnosed and treated efficiently, and they can be taught to adopt positive or healthy lifestyle behavior, improving their overall health, and where possible, whenever possible, to try to increase the use of multidisciplinary kidney health models to better achieve these results. Now, in the kidney unit where I work in Guadalajara, all of these points that I've just raised have been shown from the standpoint of research. And so we are thoroughly convinced that this is the best path forward, and that we should be committed to achieve the best conditions for our patients. I would conclude by saying that diabetes mellitus and arterial hypertension are the main causes of CKD in many countries in the world, Latin America included, and that it's important for there to be sufficient glycemic control and arterial pressure to have positive effects on cardiovascular disease and to avoid the appearance or progression of CKD. Developing new medications will also help to obtain better results in this type of kidney patient, but a pharmacological management is also important but also important and equally important are healthy lifestyles. We have to achieve the informed and active and empowered participation of patients and to encourage implementation of multidisciplinary models to achieve easier and more effectively these objectives. Thank you. The speaker is muted, says the interpreter. Thank you very much, Doctor, for that excellent presentation and the prevention of kidney damage. And now I would move on to introduce Dr. Marcelo, who is a member of the Executive Committee of the World League of Hypertension, one of our consultants. Marcelo, let's hear your reaction to the presentation we've just heard. Marcelo Urias from the Hypertension Committee of SLAN. Well, thank you very much. On this day, World Day of Kidney Health, that was an excellent presentation. I have nothing to add. You've been very clear and concise and impeccably presented by from the scientific standpoint. Now, it's great that nephrology is producing new medications that can rein in, control this pandemic of kidney disease. The sad thing is, however, that in nephrology, we have not needed new drugs. If we could do what we know needs to be done to reduce glycemia, bring down blood pressure, keep people from having overweight or gaining weight, then we would have a positive impact. Now, the difference between oncology and nephrology, during many years, broad spectrum drugs were used that were given to all patients without any type of phenotype being taken into account, no type of drug that would actually be a silver bullet on all patients. And a certain impact was achieved, but in nephrology, once we've learned the phenotypes, the medications that act in very specific sites, the progress achieved has been quite impressive. In nephrology and hypertension, we don't need that. We don't need that. We know that we can bring down people's blood pressure. We know that we can improve diabetes. We don't have to know the genetics of this disease. It must be quite complete in order to be able to rein this disease in, keep it under control. It's all based on the implementation. I think that's where we all need to place our stress. I'm from the background of phenotypes more than anything, but Pedro and others have done extraordinary work in the Americas with a world-renowned program that is a true model. Everything comes down to implementation. And so I have some concrete proposals to make. I think in scientific societies in nephrology, hypertension, diabetes, we have to have hearts committees for the implementation of hearts, which are monitoring how we can speed up the process of what is being implemented, what has been implemented in each one of our countries. These scientific committees have to make sure that universities are aware of the HEARTS program, that future professionals come into their academic and clinical lives knowing about this program with an acceptance of this program, with eagerness to collaborate with this program. We also have to make sure that we, together with HEARTS, can bring hypertension under control and diabetes under control. This is very important in this stage for us to focus on implementation. We've seen a number of presentations. Alfonso's presentation to ensure that primary health care be imbued in our countries of what with what HEARTS is. So from SLAN, the Committee on Hypertension, we have created a subgroup of people who will be trying to see what the best way to implement the HEARTS program is in all of our countries. I'm sure you're going to be hearing from us a lot. Thank you very much.
Marcelo, ¿qué decir, no?
Thank you,
tiene
Marcelo.
acostumbrado a este tipo de
Marcelo
propuestas así,
has us
misilísticas,
use this type of
entonces escribe mucho en español,
proposal
son
that's
misilito, así,
like a missile. It pinpoints the problem.
porque lo que pasa, Marcelo, la verdad es que si
But
seguimos
Marcelo,
haciendo las cosas de la
if
misma
we
manera,
continue doing things the same way, expecting different results,
pues entonces algo posiblemente no esté muy bien, ¿no? Pero
then something's not
no me voy a
right.
provocar ahora, porque
But I'm not going to provoke you
y vamos a volver a las
now.
preguntas y
We'll get back to
vamos a
that
hacer una
with
pausa,
Q&A.
tomarnos un día una pausa activa
Just
y vuelvo con
a
la
brief
tercera y
pause,
última sesión.
and then we'll come back
Marcelo, por poner
to the
por
third
ir
and
la
last
pelota
session.
en el terreno ahora y vamos a la segunda parte. Adelante la pausa activa, por favor.
Today let's make a start. It's good for the heart. Somebody say it is for health, it is for health. Give me the E for energy, E for energy. It is for all our way, it is for all our way. Give me the R for ready, R for ready. The G, the S, take the test. The T, the S, team no stress. H-E-A-R-T, carry the remedy.
Bueno, y en este espíritu de unificar, de
Now in the spirit of unifying, of simplifying, of standardizing and facilitating the first level of care work, we are going to talk about the clinical approach to hypertension, strengthening and integrating primary health care. We're going to hear from Mr. Resende. Dr. Andres Resende, you have the floor. I am Andres Resende. I'm a consultant for the Pan American Health Organization for the HEARTS Initiative in the Americas. And let me say it's a true pleasure for me to take part in this webinar along with all of our colleagues, nephrologists represented by the Latin American Association of Nephrology and Arterial Pressure. Over the next couple of minutes, we will be talking about the HEARTS Initiative and new development in it to improve controlling hypertension. I've heard the colleagues who spoke before me, their excellent presentations on the impact that the different risk factors have on chronic kidney disease and the problem that this means for the populations of a region. I would just be adamant about the concept that arterial pressure, hypertension is the main cause of chronic kidney disease, along with diabetes and obviously the rise in the corporal mass index, all of which is intimately tied to or are risk factors. And as I was saying, or we were hearing, hypertension, diabetes affect the heart, the kidneys, and peripheral vessels independently. But once that damage has been done, the pathological mechanisms that kick in, affecting the progression of the disease, and they explain why patients with chronic kidney damage have a higher mortality rate for all these causes and a higher mortality rate owing to cardiovascular diseases. And so the World Health Organization's hypertension guide, which was launched at the end of last year, picks up the glove, so to speak, and considers that all patients that have CKG have cardiovascular risks. That means they are going to need pharmacological therapy for high blood pressure, and this establishes control targets that are more strict and to keep the pressure under 130 millimeters mercury. This is very important because this includes having a standardized treatment protocol that allows for non-doctors to receive a title that would enable them to medicate for this. Now, the innovation group has recently published this publication, The Drivers. What are the key aspects that all programs that seek to achieve improvements in cardiovascular risk factors should carry out to be successful? These 8 drivers for controlling arterial pressure, also take into account those patients that have CKD as a risk group that deserves special care, not tied to treatment only, but frequency of follow-through and other treatments that happen at the same time, like statins being administered. Now, going back to protocols in this World Health Organization guide, it places emphasis on the fact that Hearts in the Americas for the last 5 years has been promoting in member countries this initiative, and that they define their own standardized treatment protocols. We have to make very clear what the difference is between a model that works with a treatment protocol and one that does not. Now, this is based mostly on the fact that those models that do work under a standardized treatment protocol broaden professional skills of all of the healthcare team and not focus only on doctors. And this multiplies the scope and reach of the care given, including the vast majority of the population, establishing courses of action that are precise. The main realm of care at this first level of care, where most patients go, that makes it more efficient to buy and provide medication, raising the percentage of hypertension, arterial hypertension control and coverage. Hearts of the Americas, as I've said, has established a path by way of proposal to the countries for them to define their or update their protocols using the resources they have available to them currently, but in the midterm, hopefully they would be able to optimize the endowment of such resources so that ultimately they can achieve a robust treatment protocol, an ideal one, the best one possible, once they have those necessary resources that science tells us we should be using. Now, this process of creating protocols, this is an effort Hearts has been engaged in for a number of years, and this has been bolstered by a new innovation, which means to add to the current treatment protocol that countries have strategies to to correctly screen and diagnose hypertension or arterial pressure, how to estimate cardiovascular risk, to stratify patients, how to improve the care, diabetes care, and that of chronic kidney disease, how to program follow-up for control of cardiovascular risk, strengthening prevention, secondary prevention, by administering aspirin and statins at different intensities, depending on the patient's risk, how to administer medication with what frequency and reducing the vulnerability to infectious diseases. These innovations that have strengthened the standardized treatment control give rise to the clinical guideline for hypertension control, which is the focus of my presentation, and that was just published by Lancet Health. You can see the reference here, Lancet Regional Health. Now, this provides the ABCs of comprehensive control of hypertension, arterial hypertension. And so pass A has to do with diagnosis, the correct diagnosis of this condition, establishing a broad screening strategy, taking arterial pressure, using the correct techniques in all patients that have a contact with the healthcare system, and to use automatic blood pressure monitors that have been validated for the use on people's arms. Once that diagnosis happens and patients have to be classified, development based on the largest cardiovascular risk model that exists, which is that of WHO, which has been translated into a pragmatic calculator, which is can be found on the Hearts app. There are other resources defined by each one of the countries of the region. Now, C, at the center, which is a standardized protocol for hypertension control and cardiovascular risk at the clinical level, we have to initiate treatment regardless or independently of the risk level determined. As soon as hypertension is verified, that should not, the fact that they should be satisfied does not mean that one has to wait until that happens before offering treatment. Looking at all the different drivers of hypertension in the heart system. Now, 140/90 being the threshold to start pharmacological treatment for all of those mild and moderate levels of hypertension. For the high risk patients, diabetic patients, those for which a risk threshold has been determined 10% using the calculator, and those that have sustained damage to their kidney function should start pharmacological treatment with a lower threshold of 130 blood pressure, systolic blood pressure, and that differentiated methodology for control be used for the whole population. 140/90, usually more strict one for that for the whole population, a stricter one for those. Our goal would be then for 130. Now, high risk patients, if there's a presence or not of cardiovascular or chronic kidney disease risk, they can be started on aspirin, and to graduate that or to move on to the use of statins. Now, pharmacological anti-hypertensive treatment is fundamental. This protocol standardized aligns the messages of healthy lifestyles with intervention policies in the population, the global heart strategy with the technical approach, reducing alcohol consumption, front labeling, salt consumption reduction, not smoking, so forth, all this within a broader strategy which seeks to intervene at different levels. And pharmacological treatment per se establishes only 4 steps for therapeutic treatment to more quickly achieve control of arterial hypertension, defining maximum intervals of 1 month to reassess the patient and to decide if the hypertensive treatment or pharmacological treatment be increased or not. This has become standardized after the publication of the last hypertension guide of WHO that was issued, as well as incorporating a key driver for controlling arterial hypertension, which has to do with systematically repeating or the measuring frequently blood pressure. We know that the first measurement might be falsely, they might get a high reading, so that has to be done frequently. So the scope of primary healthcare, where the largest proportion of society is seen, that's not only the best place for measuring arterial hypertension, cardiovascular risk, but for the patient to reach stage 4 before thinking about a second level of care.
And now moving on to the basis of this standardized treatment, the addition of other key drivers for the control of hypertension and cardiovascular risk, such as the minimum follow-up interval for those patients that have controlled hypertension, where we establish more frequent intervals for high-risk patients, such as those that have chronic kidney disease, the administration of medicine that for those patients who comply with treatment to guarantee adherence and also avoid interruptions in treatment. We add other recommendations to reduce the vulnerability of the patients before infectious diseases such as influenza, pneumococcus, and COVID, and the pandemic that is still with us has also uncovered the risk for all of these patients who have chronic kidney disease, diabetes, and established kidney disease or multiple risk factors, in particular in connection with cardiovascular disease, and the impact this has in other diseases and death. They recommend assessing this in each visit, and also something that is very important, and once again, in connection with adherence, they also recommend just having one administration of the medicine. If the countries do not have combined treatments in just one pill or fixed doses, and they need to administer various pills, the recommendation is to have this as extended administration, to do it once a week and for all the pills to be put together in just one administration. To conclude, I would like to state that the position of cancer in the Americas in connection with the clinical hearts in the Americas in connection with the clinical path is to have this better approach, since it focuses on the control of its main risk factor, which is hypertension, and also for patients that have some degree of undermining or damaging heart, intensifies interventions to delay progression to therapy, to replacement therapy, and also to reduce the risk of cardiovascular disease and early death. Once again, I conclude as I started. It is a pleasure for us to have you on board, and we are hoping eagerly to continue to build upon what we have built and to continue to work in coordination to attain kidney health for all. Thank you very much. Thank you, Andres, for this excellent presentation. The time is never enough to look at all that we have here at hand, but we are going to try to see and fix this I'd like to have more time for comments and questions, but we're going to see how we can do it and see if we can catch up. Now I would like to give the floor to the last presenter, Jenny Rodriguez, who is a consultant with heart. She's in charge of the educational and technical tools we have, and taking advantage of our large audience who will be watching this on YouTube. You will have our presentations, you will spread the word to have Jenny sum up the new developments we have in the Americas with hearts. Good afternoon. Thank you for this presentation. My name is Jenny Rodriguez. I am a clinical cardiologist and I am a consultant with hearts in the Americas, and I coordinate training and education with the health teams. Today, I will be showing you the common shared tools in the area of heart and kidney education at the primary care level. PAHO recognizes the relevance and also promotes access to training of healthcare professionals. We have been working with SILAN to provide answers to the needs of the health teams. The question is why it is so important to train first level of care professionals. This is important for the treatment and referral of these patients, as well as their identification. A trained clinician may reduce therapeutical inertia, and as a consequence, there will be more patients who are better treated. And it is also necessary to exchange roles with individuals from the pharmacy area and also from the management area to better address that population that is seeking medical treatment when we do not have enough specialized doctors. We know that the rates of prevalence of kidney therapy per million of inhabitants in Latin America are increasing, as we heard in the first presentation. And then Dr. Alfonso indicated that hypertension is the second most frequent cause of kidney disease in its terminal stage. So there is one or several things that are not being done right. As to the prevention of chronic kidney disease, the Pan American Health Organization and SLAN have implemented efforts to educate first level of care practitioners and also to improve the capability for treatment and management of chronic kidney disease. Blood pressure is responsible for a high number of cases among individuals that suffer from kidney disease. Imagine what would happen if a clinician or a person who is in charge of measuring blood pressure doesn't do it correctly. In hypertensive patients may be left without treatment, and patients who do not need treatment may be treated. So the first scenario is more
silente del paciente que es hipertenso y luego puede llegar
alarming because this may be leading to damage, and the person may have an acute myocardial infarction or also anemia, also stroke. And this is a moderate to advanced situation that could have been prevented. It is also quite common for the patient to reach the healthcare center with extreme headaches, and the person is in that case undergoing different tests such as glomerular filtration, and the patient, let's say, that has 50 ml of filtration. That means this is stage 2A of a chronic kidney disease. And in addition to that, the clinician admonishes the patient, and in some cases, this is quite common. Why didn't you measure your blood pressure? And the patient said, well, I came to measure my blood pressure and I went to the pharmacy and it was always normal. For these situations to be less frequent, we need to train. And for that, we need to continue training the health teams with all of the resources we have at hand. Together with SLAN, PAHO has offered the health service groups 3 courses, one for the management of chronic kidney disease in English and Spanish, peritoneal disease management that includes the role of nursing and also the management of the patient with this problem. And then finally, the acute kidney disease patient that has been recently offered by PAHO. Each course has a very specific organization with video and also a theoretical portion. It has been properly qualified in the satisfaction survey that is completed by the participants. Up to 97% of the participants have completely agreed that these courses have been useful for their clinical performance. We would like for kidney courses to be supplemented with courses on cardiovascular disease, in particular the one on the proper measuring of blood pressure that address in separate modules the treatment and management of diabetes mellitus type 2 based on hearts, its information, and also the management of kidney patients with hypertension. This is an invitation for those participants that have remained here up to the end of this virtual seminar so that they can attend these courses and also become spokespersons for this information and courses. It is also to be highlighted that the new calculator of the HEARTS application has been improved. It was updated and a new section has been added prior to the inclusion of the data of the patient, such as age, weight, and smoking. The clinician may select whether the patient already has a pre-established diagnosis of chronic kidney disease, and then it is possible to see that this is a high-risk patient, as well as suggestions for follow-up. If the patient does not have any established diagnosis for chronic kidney disease, the clinician may estimate the cardiovascular problem and also the glomerular filtration. Here we have health professionals who are motivated to, and also with free resources of excellent quality. The resources are available on PAHO's virtual campus. There are several gaps, such as access to internet in some areas, which is quite limited. And the calculator for cardiovascular risk may be downloaded by using internet, but later on it can be used in a rural area where there is no internet. So this allows the clinician to quickly estimate the cardiovascular risk and also to estimate the level of glomerular filtration. The courses are believed to be created for doctors, but that is not the case. They were created for all of the primary care team, including nurses and pharmacists, among others, and also the resistance to new information. We continue to see resistance to the acquisition of appliances and devices that are validated for blood pressure monitoring, not only at the management level, but also at the individual level. The doctors, the specialized doctors, oftentimes avoid using a validated automatic device. The guidelines are there. PAHO has published a guideline, and Hearts in the Americas continues to reinforce this aspect. The initiative is committed to promoting actions to effectively overcome the pandemic of hypertension. Hearts in the Americas is a program for managing hypertension, heart risk that includes diabetes, and also this disease as part of the care. Therefore, we also invite all of the clinical staff to visit our web to become more familiar with our resources, to download the cardiovascular risk calculator in their on their phones or tablets to estimate the risk of their patients and also to make therapeutical decisions based on the results obtained, but for all of this to be done timely. That's the reason why training is key and virtual courses offer this opportunity. Thank you all for your attention. From Hearts, we support kidney health for all, and I leave you with the fragment of one of the videos produced by the Public Health of School of Johns Hopkins for the exclusive use of our virtual courses. Please go ahead. This is for the technical team.
Vamos a resumir los puntos más importantes.
We are going to sum up the most important topics. First, the treatment of hypertension may reduce the risk of death and diseases related to hypertension. Second, changes to lifestyle and also medicine to reduce blood pressure are two types of treatment to control blood pressure. Third, to maintain healthy diet that includes a large number of fruit and vegetables, low salt consumption, and an increase of physical activity are key changers of our lifestyle. There are several types of efficient medicines that are low cost and that have a low risk of adverse effects. Fifth, treatment of hypertension is a lifelong treatment.
Bueno, muchísimas gracias.
Thank you very much. Thank you to all the colleagues. I said that we are running out of time. And just to digest all of the information that we are receiving today, I promise you that we are going to emphasize more on how we can use this time in a more productive fashion. I know that this is a very interesting topic. We have a lot to say, but finally, I'd like to offer the word to Adriana Roballo, who is the last one to make comment to conclude this block. Adriana Roballo, please, you have the floor. Good afternoon. Good afternoon to you and to all of the participants with PAHO and SLAN. These topics will never be redundant. We are determined to continue to work from PAHO and SLAN to share this information with specialized doctors and clinicians. It is important to bear in mind the challenges of implementation. Many of us are left with how we can take this to some documents that are user-friendly and more understanding. We would like to have a basic level so that individuals can benefit from this without having a PhD or a specialization, and so that this information is applicable. As I mentioned before, the documentation will be made available, but this HEARTS program has been working on implementation at the same time. We have been working on SLAN, and PAHO's platform will be sharing this information so that it becomes more, that it is easier to apply. We need to look at the quality of the documents or specific documents, and we have pictures, diagrams, or the videos are also very good quality, and we think that this is a highly important tool. And it is also important to mention that these documents are not going to reach everyone, but also the digital section has to be complemented, so has to be supplemented so that everyone can benefit. Sometimes the most vulnerable population is the one that has the least access, so we need to see how to have access to this. We understand that we have different situations, so at any rate, this helps us maintain updated knowledge and also to take this information to everyone. From the association, we'd like to send greetings to the hearing, to invite them to attend our courses. And we understand that these have been highly coordinated with PAHO to maintain a very interesting conversation. This is my comment. I'd like to continue working with all for the well-being of the Americas. Thank you very much, dear Adriana, for your closing remarks. I was saying that I wish we had more time, but I am going to ask the panelists to turn on their cameras. We are concluding this webinar. I think that we went over time, but it has been interesting to see each of these topics. And part of the issue we are dealing with today is how can we make it possible. What we already know is that the gap that we have between what is known and what is done is significant, and the greater gap we have, the fewer chances we have to benefit. So those who are working on basic science make up things, but then those that work on clinical sciences and make up things cannot take it at the level of the population. And also the audience at the first level of care will require other types of instruments to be able to implement this. Marcelo. Marcelo usually challenges us, and he wears several hats, but he has been quite active in trying to have the World Hypertension Association to say, okay, let's go to the first level of care. That is where people live. That is where the individuals are diagnosed. That is where most individuals are managed in terms of their conditions. Marcelo, and I would like for Gloria to help me with this. Gloria has been one of the architects of this task. She has, this is HEART's implementation guide. We just published the English version, but soon we will be publishing the version in the same guide into Portuguese and into Spanish. Right now we have 1,380 first care centers that we just counted a couple of days ago from the countries implementing this. We need to continue to increase the number of countries and centers. But Gloria, could you please show us this guideline? And that guideline, published by HEARTS, includes the document as to how HEARTS is to be implemented step by step. You have the protocol, you have the clinical guide, you have also the calculator for the heart risk, you have the virtual courses, and all of the literature that we have. Let me call your attention to this. And the other topic that I wanted to share with the audience is HEART has just been awarded the prize from the World Heart Federation in its role as an advocate for cardiovascular health, and prior to that it had been awarded the prize of the World Hypertension Association due to its advanced work in controlling hypertension and controlling cardiovascular disease. So with these resources, I would like for all of us to participate. There is a very large number of individuals who are not here today, but the idea is that for those who participate to share the information with their colleagues so that they can share this with the other actors. We will continue to work with Lan, Guillermo, certainly. Now we need to focus on the priorities. We cannot do everything at the same time. We need to look into our priorities, and the priority for HEART is to enhance the number of countries that are implementing the initiative and also the number of health care centers that are implementing this. Then let's implement this guideline for hypertension that controls hypertension, but also secondary prevention and high-risk hypertensive individuals that includes chronic kidney patients, chronic kidney disease patients, and also individuals who have cardiovascular disease. So once again, this is our commitment that we will be doing this together and that there is room to continue working. I'd like to thank all of the panel members for the excellent presentations. I hope we can take it home and share this with our colleagues. And Marcelo, since you started with this and since Marcelo is such an important actor in hearts and Marcelo Zúñiga were our nephrologists, the first ones who participated, and there they are. Would you like to close the webinar with me? Go ahead. Thank you, Pedro. As I mentioned before, what Hearts is doing is clearly highly important, and my comment is how can the specialized doctors leverage what is being done at the level of the public health and the ministries. And I imagine this from the point of view of the society who is thinking who works in what hospital, or whoever is working at a hospital, can we contact them? Can we bring them over? And also, who is trying to work at the first level of care? Certainly the ministries, there are several connections, but the scientific associations also need to help, as I mentioned before, those who are at the university level and also at the various chairs that are teaching prevention. How can we act as catalysts for this knowledge? Because Hearts is one of the few successful initiatives that we've had, and we need to have that level of success. Thank you very much, Marcelo. Thank you for the thrust. Thank you very much for the support. We have our SLAN president. Would you like to share a final comment? Well, it is our commitment to strengthen hearts. And I think that we have a team that is working from the nephrology section, and we can offer that group to the primary care doctors and to the heart structures so that in case of any guideline they might need in the area of nephrology, they may receive those guidelines virtually, and we can cooperate, and we can also offer to hearts all of our educational platform to continue to promote this platform, and as Marcelo said, to take it to those work teams and also to stimulate those work teams so that we know more as time goes by. So thank you all. Thank you for the participation of Pedro, Andres, Jenny, for all of their cooperation and for this opportunity. I think that Pedro and is, as well as we are, is responsible for creating opportunities so that this initiative can be implemented in an efficient manner to control hypertension and the risk factors leading to chronic kidney disease. Excellent, Guillermo. And I would like to greet all of the panel members. I think that you have addressed some of the questions in the chat. There are some specific questions that you may have addressed already. We do not have time. Thank you all. I would like to thank our audience for having been with us for almost 2 hours. And I hope to have another chance to meet again. Look at the chat, and you're going to see the implementation guide for hearts. All of this is available here. For example, if you do not have the heart risk calculator, well, it is right there. So you can download your calculator onto your phone and also share that with your colleagues. Good afternoon to all of you. Happy World Kidney Day. We finished today at 3 p.m. So see you all. Good afternoon. Have a good rest of the day and let us continue to fight. There is a lot to do. See you later. Thank you very much.
Música, maestro.
Hi, I'm Dr. Mark Jaffe. I've spent 25 years treating patients for hypertension at Kaiser Permanente, where we improved blood pressure control rates from 44% to 90%. I want to share with you why it's so important to use an automated digital blood pressure monitor. To increase control of high blood pressure, we need to make sure hypertension care happens where most patients get treatment, and that's in the primary care setting. To take blood pressure with the manual device, you need to do many things at once. Use your fingers to control the deflation rate, use your eyes to read a small dial or mercury column, and use your ears to listen for the sound of blood passing through the artery. Doing this right takes a lot of training, and even experienced staff make mistakes. Now, an automated digital monitor does all the difficult stuff for you. It inflates to the proper pressure, and it deflates at the right speed. It displays the numbers on an easy-to-read screen, and it doesn't require any listening. As long as you get a monitor that's validated, you can be confident that it will be accurate. Since an automated device is simple to use, training is easier and faster. That means healthcare workers can pay more attention to things like positioning the patient. Specialists might use other ways to measure blood pressure, but for primary care, automated digital monitors are the way to go. Hypertension treatment programs have saved many lives already, and automated digital blood pressure monitors can help save millions more.